Good morning, everyone. Happy Thursday. It's bright and early here in San Francisco, but it's the opposite of that where my co-discussant Anmol is in India. I will recount the story of bumping into Anmol, and it was a very, very prominent collision because she showed up on VMR a few months ago and has never left. Case after case after case. Uh, an hour of continuous smiling after an hour of continuous smiling. And it was just impossible not to soak up that wave and invite Anmol to the academy. And we're so thrilled. I think she actually has set the record for the fastest time from invitation to becoming a leader in an internal project, which none of you know yet. She knows a little bit, but it's happening soon. And I hate to foreshadow things, but it really just symbolizes how awesome it has been to see her grow and shine in this space. And um, I'm really, really excited for your future. I'm excited to bookmark that journey by reflecting in the future on our first ever case discussion. And we get the privilege of doing so together on Mole with a seasoned VMR legend presenting uh, yet another case today. So Anmol, I'll hand the mic to you to say hi, and then maybe we can pass it to Hans.
Hello, everyone. Thank you so much, Dr. Ravi, for these kind words. And these words have always kept me going in the academy. And thank you so much for that. So, hello, my name is Anmol Preet, and I'm an international medical graduate from Punjab. And I became an academy member in December. And I am forever thankful to CP Solvers for that. And they have made my gloomy days better with the beautiful cases every day. So yes, it's me who has the honor of being the academy member.
Let's just share it, okay? How about that? Hans, good morning.
Good morning.
Hans, I think there's maybe one or maybe even a half a person who doesn't know you. Probably not a whole person. Please, in case there's somebody new here in VMR, do you mind telling them a little bit about yourself?
Yes, I graduated from Rust University. I intend to participate in the match that is upcoming now. And I've learned so much by attending VMR. I can't even tell the whole back and now RLR as well. So both are really fabulous. So now I have the honor of presenting a case, and it will be a very nice one.
I think so. It always is. Yeah, I think we can ready to rock and roll. I think Parisa is doing our scribing today. Thank you so much, Parisa. Um, I see we had Tansu sign up for teaching points, but I don't see her here yet. So, Anmol, I think in true fashion, Anmol fashion, you and I can maybe just narrate some teaching points that we learned at the end so that folks can sit back and relax. How does that sound? Okay.
Perfect, perfect.
All righty. Okay, Hans, we're ready whenever you are.
Okay, today I present a 50-year-old male, and he comes to the ED with the chief complaint: I have been throwing up blood for 1 day. And that is aliquot number 1.
Oh, a master case presenter knows exactly when to stop. Anmol, have you ever seen this throwing up blood before? In real life, I mean.
No, I don't have much
Yeah.
experience. I have not.
Yeah, no,
Not in real life.
this is the value of practicing these cases because it gives you the sense of being more prepared when it does inevitably happen. And I'm curious, with you hearing this, and I want you to try to picture yourself in real life. You are sitting there in your room, and your patient just said, "Hey, I threw up blood for 1 day." What do you think you might get? What do you think you might want to get next in terms of information from the patient?
Yes, I think when the patient is vomiting or out blood, then a first thing I want to check is vitals. If the patient is hemodynamically stable or not, first thing will be to monitor, treat the patient for that. For the vitals if they're abnormal, and then I would want to know if the patient is having any alcohol history, because of which this can happen, and apart from that, I think the presence of or absence of fever can also be a clue in this case, because sometimes in pneumonia, like for example, in the involvement of lungs as well, we can see throwing up blood. So that's what I'm thinking, that the first thing will be to hemodynamically stabilize this patient, and then we can evaluate that what the cause or what the source of the blood is, if it is in the GI tract or
Excellent.
it is somewhere else.
Absolutely superb. Anmol, I think that what you are essentially saying is the diagnosis that people would jump to, hematemesis, has to be verified in two ways, because there are two components of the word hematemesis. There's heme and there's emesis. And when somebody says, I'm vomiting blood, you first have to make sure that they vomited it, meaning that it came from their GI tract. And then you have to make sure it's blood. And so it could be hemoptysis, or it could be upper airway bleeding, like nasal bleeding. So the first step with the vomiting blood is to really try to make sure which orifice is it coming from. And my recommendation is to always translate throwing up blood to blood per orum from the mouth. And that helps you realize, is it from the back of the mouth? Is it from the lungs, or is it from the GI tract? Anmol, if you were to think, and I agree with you that you're going to try to get hemodynamic parameters. If you were to believe that this patient has hematemesis, I love that you asked about alcohol use. How might you connect alcohol use to upper GI bleeding? What are the diagnoses that you know that are associated with alcohol use?
I think what I was thinking, that with like frequent vomiting,
Yeah.
for example, in alcohol use disorder, we can have this thing of frequent vomiting, which can cause esophageal tear and the Mallory-Weiss syndrome, and that's how the patient can present with bleeding. That's in the esophagus, or if or if we go down there, we can have some maybe peptic ulcer disease in the stomach, which can present like that, maybe not connected to alcohol, but something else.
Yeah.
And yes, that's what I was thinking.
Yeah, absolutely. So if you're in the esophagus, a Mallory-Weiss tear has a strong link with alcohol use and the recurrent vomiting, as is alcohol-induced gastritis, for sure. What if you later learn that this patient is jaundiced and drinks a lot of alcohol? How would you tie those two together?
Um, Okay, so this just makes me recall one of the cases I saw,
Yeah.
where the patient had, like, from last 15 days, he had lots and lots of alcohol, and then he had acute liver injury. Ammonia
Yeah.
levels were 215, around
Wow.
that. So that was type A hepatic encephalopathy, as you taught us. But that patient also, if I say, so maybe because long-standing alcohol damaged the liver, causing cirrhosis, which caused esophageal varices, and then maybe the
Exactly right.
bleeding.
Exactly right. In this moment right now, there's only three things that matter. Is the diagnosis of hematemesis correct? How hemodynamically unstable is this patient? And lastly, does he have cirrhosis? And you can establish these things with your eyes alone by seeing if there's jaundice, ascites, caput medusae, by looking at the vital signs, and by looking to see if the patient has any upper airway bleeding that could mislead you, or the patient has any dyspnea or cough that might suggest hemoptysis, not hematemesis. So I think the first few seconds with this patient are going to be very, very important. But I would say it's really important to classify a patient upper GI bleeding with cirrhosis or upper GI bleeding without evidence of cirrhosis. As a fun quiz, not for you, Anmol, because it's very rare, but for the chat who has more time, there's another life-threatening cause of upper GI bleed that you should try to establish now. But we'll answer that question later in the exercise. It's not as common as cirrhosis, but it's more deadly. All right, Hans, why don't you give us more information?
Okay, then the history of present illness. As mentioned before, it is a 50-year-old male who experiences hematemesis for the first time. He describes the bleeding as profuse, with a total amount of 2 cups of fresh blood for 1 day. There is no food in the vomit. During the past month, the patient had several attacks of epigastric pain, which he treated with analgesics. The kind of analgesic he took was whatever was available for him, ibuprofen, and that alleviated his pain. He denied any exacerbating conditions that make the pain worse. Then I have the review of systems in this aliquot as well. So when he was asked a few more questions related to medical problems, the patient denied liver disease. And in this respect, he also denied the consumption of alcohol. He admits to feeling tired almost all the time recently. He has been smoking 5 cigarettes that he admitted just on his own, because he also noticed that he had occasional mouth sores, maybe from smoking cigarettes, and his eyes are getting sore occasionally too. He denies alcohol, as I mentioned before, and he admitted to smoking cigarettes. He also noticed that occasionally it is painful for him to go and urinate, so painful dysuria. That was occasionally treated with antibiotics. And this would be the end of aliquot number 2. Now,
Oh, Hans, you're such a seasoned presenter. Thank you. You guys are watching Hans bookmark every single aspect of the presentation. Now the review of systems and presenting so clearly. Thank you so much, Hans. Anmol, I have to admit, I'm no Hans. There's no way that I would have been able to get this history from this patient. I would have just been like, you were having hematemesis? Okay, I don't need any more HPI. Let's get the vital signs of the exam. But it goes to show you how once you stabilize the patient, you really have to go back, because this review of systems is incredibly rich and very informative. But maybe before we talk about the review of systems, maybe let's talk about the rest of the HPI, where we learned that he's having 2 cups of fresh blood and that he has epigastric pain alleviated with ibuprofen before he had bleeding. What were you thinking when you were hearing that information?
Yes, it just made me think that the patient was initially having some a problem in the, like, probably in the stomach, could be possible, right? Like
Yeah.
right now, I'm just assuming, but the analgesics or the ibuprofen, it exacerbated that because of it has a tendency to induce peptic ulcers, or and it can cause acidity. And yes, that was what I thought, maybe some problem in the epigastrium. So going towards the age of the patients, I was thinking what could cause that. And I'm thinking if smoking has any role to play in that. So I was not able to connect what could be happening there. Maybe a peptic ulcer disease, but I'm not sure.
Yeah, I think so too. I think when you see epigastric pain, you don't know if it's gallbladder or stomach or anything really. It could be small bowel even. But when the patient then has bleeding, I think you then localize it to the gastrointestinal tract. And I think it's interesting to see that the pain was alleviated by ibuprofen. And now the question is, did he have some other issue? Maybe he had a musculoskeletal pain, and now he then developed NSAID-induced peptic ulcer disease. So it's hard to know the sequence of events. But then now we really confirm that he's having hematemesis because he's not coughing up this blood. When you cough up 2 cups of blood, you cough it up from your lungs. It's very violent and loud. So I think the fact that it's just coming up is very suggestive of hematemesis, which I think we've confirmed now. So now, Anmol, I'm going to ask you a very hard question. It's not a fair question, but it's a good exercise. So what do you think is more deadly, An upper GI bleed or a lower GI bleed? What do you think?
I think
What's
both
your
of
guess?
them are deadly. Okay, so
It's true. They are. That's why
um
patients get admitted. But what do you think is more deadly? And you all should put your thoughts in the chat. What do you all think? What is more deadly, an upper GI bleed or a lower GI bleed?
I
Or
think the
morbid?
lower GI bleeds are basically they could be like some malignancy as well. They must be difficult to treat because they are could be due to malignancy. And upper GI bleed is mostly fresh blood. I'm not sure. Maybe upper GI bleed. I'm not sure.
So the answer is Rabih is really, really annoying, and they're both equally morbid, the exact same morbidity. Why? The truth is that what actually matters more is not if a patient has an upper or lower GI bleed, it's how brisk the bleeding is. So in all comers, the rate of brisk upper GI bleed equals the rate of brisk lower GI bleed. What gets really powerful is the mode of presentation. An upper GI bleed presenting as melena is not acutely morbid. But an upper GI bleed presenting as hematemesis has distinguished itself as being a ferociously fast bleed, so much so that the stomach is distended by its ferocious pace, and instead of trickling down into the small bowel, it is hurled back up into the world. A lower GI bleed can be just as brisk and just as morbid, but the manner of presentation of an upper GI bleed with hematemesis or coffee ground emesis has subselected a small subset of upper GI bleeding to overrepresent those ones that are especially morbid. So the answer is that upper GI bleed and lower GI bleed are just as morbid as each other. But the most morbid presentations are upper GI bleeds presenting as emesis because the velocity by definition is high enough to distend the stomach and cause vomiting. The only exception to that is upper GI bleeding that is beginning proximal to the stomach, like an esophageal irritation, because you are bringing up the blood because of irritation, not because of overdistension of the stomach. So this patient, by virtue of bringing up fresh blood, is bleeding quite a bit. And these patients are, by definition, rapid GI bleeds. And so in him, the reason I wouldn't have heard this excellent history is because there's too much morbidity on the line not to act very quickly. And that's really why. Any questions about that before we analyze the nice data that we have?
So basically, upper GI bleed can be more morbid because of the risk of aspiration as well.
Yes. The risk of aspiration in upper GI bleed is very prominent and noteworthy for sure. If all you know a patient is having an upper GI bleed or a lower GI bleed, you don't really know who is more sick. But if an upper GI bleed, well, I should say one more thing. Most upper GI bleeds actually present with melena, vast majority of them. About 80% of upper GI bleeds bleed slowly from the stomach or the duodenum into the lower GI tract. Only a small fraction of them bring up the blood from the mouth. So the short answer is, what's more morbid, an upper GI bleed or a lower GI bleed? They're both the same. What's more morbid, bleeding from the mouth or bleeding from the rectum? Bleeding from the mouth. Why? Because bleeding from the mouth subselects a population of people who are bleeding so much that their stomach gets distended and that they vomit up the blood. So you cannot have a slow GI bleed present as hematemesis. Impossible. You can have many GI bleeds that come out of the rectum that are very slow. Okay. All right. So what did you think about this review of systems? Where did you go with that?
Yes, so feeling tired all the time and it can have so many differentials. If we count it as generalized weakness or asthenia type of a picture, it can give you an inflammatory kind of a signature there. Maybe looking at the hemoglobin will be helpful as well, because everything, I think, it's not ideal, everything is multifactorial. So but this thing of mouth sore or eyes getting sore, maybe if they are trying to signify that eyes are getting dry and mouth is getting dry, then maybe we can think about the diseases which can cause decreased secretions like Sjogren's syndrome. So that's what I thought about it. And pain in urination or dysuria. When we have UTI in a male, that is a very rarer than females. So that is also one thing which, because it was treated with antibiotics, so maybe urinalysis will help in this case. So that's what I'm thinking.
Love it. Absolutely superb. I'll just plant the seed that there's a lot in common with the eyes, the mouth, and the urethra. These are all mucosal surfaces. And guess what else is a mucosal surface? The inside lining of the stomach. So what this person has is a subacute progressive mucosal disease of the eyes, of the mouth, probably of somewhere in the upper GI tract, and of the urethra. And I think framing him as such allows us to really make progress in the future, but it doesn't matter now. We should stabilize the patient first. All right, Hans, tell us more, please.
Then the next aliquot, the southwest corner, and our physical exam. The past medical history, just as mentioned before, the painful dysuria, the mouth sores, and hypertension that is treated with ramipril and hydrochlorothiazide. That's already the only medications that he's on. Family history is unremarkable, and social history is unremarkable as well. He's married, he works in an office. He has never had any STDs or STIs. He admits to smoking cigarettes and no alcohol at all. The physical exam, the vitals, his temperature is 37 degrees centigrade. The blood pressure is 90/60. Heart rate is 100 per minute. Respiration is 16. And his saturation is 98 at room air. General, the gentleman is in no distress, but mild jaundice is or was seen. His BMI is within normal limits. At the same time, when HEENT, he has no mouth ulcers at all, so everything was fine in the mucosal area. Then his heart, it was a regular rate and rhythm, no murmurs, no gallops, so all within normal. Lung, clear to auscultation bilaterally, so pulmonary is within normal limits as well. The abdomen, close inspection, showed no stigmata of liver disease, both in the abdominal area as well as hands and feet. There is no ascites, there is no tenderness, bowel sounds are present. However, a mild hepatosplenomegaly was noted. Lower extremities, we have no edema, no ecchymosis, or no petechial lesions. And that concludes aliquot number 3.
Very interesting, Hans. Thank you so much. Anmol, what happened to your thinking with this information?
Yes, thank you so much. I think what we were thinking about the blood pressure, maybe the patient was going into a hypovolemic shock-like picture, which is seeming like that right now because of the increased heart rate and the blood pressure. But what we thought about the jaundice, so the patient is having the jaundice indeed. So that will be an important thing to evaluate. For example, if going towards the labs, the fractionated, if you fractionate the bilirubin, indirect or direct bilirubin, it will be important to know that if it is indirect bilirubin which is high or direct bilirubin which is high. And looking at the hepatosplenomegaly, it makes us more concerned about a rise in indirect bilirubin, but that will be confirmed by the CBC and what we'll see ahead. And with no stigmata of any liver disease and no ascites, we kind of right now put aside the picture of cirrhosis. We don't really rule it out, but we just keep it aside. And um, then I think that's what I was thinking, that maybe now looking at the labs, it will be really helpful looking at the CBC. And about the, yeah, that's what I'm thinking right now.
I absolutely love it. I think that your caution about translating the jaundice into direct or indirect is very valid. Even though there is liver involvement here on exam, that's definitely not pathognomonic or confirmatory. I think one really helpful exercise for us to do now on Mo is to really put ourselves in the shoes of Hans taking care of this patient and say, okay, we're going to get the labs 1 hour from now. The patient has a heart rate of 100 and a blood pressure of 90/60. So I'm really curious, what do you think you will try to do between now and 1 hour from now when the lab results return? What will be your goal?
I think the main goal will be to stabilize the patient using fluids, IV fluids, and other than that, we can, I guess, examination part is done, and maybe the main thing will be to stabilize the patient. I think in this case, to get the blood pressure to the correct parameters. And I don't know what else should we do. Sure.
IV fluids is going to be really, really key, right? I love it. And when you think of gastritis or peptic ulcer disease, and if you pretend you know that, what kinds of treatment do you think you might offer a patient who has gastritis or peptic ulcer disease?
Maybe we can start with the do you think we can start with the presumed H. pylori treatment? The presumed we start that triple regimen. I'm not sure. Do we start?
What do you think, what is involved in the triple regimen? Do you remember? There's antibiotics and there's one other medication. Here, let me ask you another way. What do you think the pathophysiology of the ulcer formation? What causes ulcers to happen? What substance
Yeah.
accumulates?
The acid in the stomach.
Yeah.
So we can go for the proton pump
Exactly
inhibitors.
right. So you're going to give this patient IV fluids. You're going to try to give them proton pump inhibitors, IV PPI. Do you think this patient might need blood transfusion?
It just depends on the hemoglobin, but currently we don't have it. And I think I just learned from everyone here that hemoglobin, it actually takes time to drop. So maybe we can check for the pallor in the eyes to just confirm that if the patient is indeed anemic.
So what's really interesting is, so Anmol, if you see that the patient is anemic and then you want to give them blood, you then have to get a type and screen, and then you have to wait another hour for the type and screen to come back, and now you're 2 hours behind. So whenever you're trying to manage a patient with a presumed GI bleed, the first step is we often try to get 2 large bore IVs, very nice, juicy intravenous access. Then we send a type and screen to be prepared for the need for transfusion. And then we start to think, okay, how can I treat this person? And let me show you how we do that. There are some things that we always do, and that is to ask our nursing colleagues to get IV access, to send a type and screen, and to always give an intravenous proton pump inhibitor. As you are giving, remember to take away blood thinners, diuretics, and blood pressure medications and stop those, okay? And then sometimes We treat for portal hypertension with octreotide and ceftriaxone for SBP prophylaxis. Sometimes if the patient is on a blood thinner, we reverse their blood thinner, like giving FFP for warfarin. And then sometimes we get CT scans, but that's not relevant today. So we're going to get IV access, a type and screen, IV PPI. The question, my dear friend Anmol, is right now, do we treat for cirrhosis and do we not? I think I would. And here's why. We don't know if this patient has cirrhosis or not, but he has jaundice. And the efficacy of octreotide is very, very high. So our threshold to treat for presumed portal hypertensive bleeding should be very, very low, given the morbidity of the disease and the rapid ability to be able to exonerate it. So I think octreotide is with minimal harm and with potentially astronomical benefit, that I think in this situation, it probably would be a good idea to give it to the patient. I think it's a judgment call whether or not to give this patient blood right now. But let me make the argument that there is no other reason for him to have a heart rate of 100 and a blood pressure of 90/60 apart from blood loss. And in fact, we know that he's lost a significant amount of blood should he be this tachycardic and hypotensive. We transfuse people for two reasons. One is their hemoglobin is low, less than 7, no matter what the cause of the anemia. And we transfuse people who are actively bleeding. And we should not confuse those two indications. If your hemoglobin is less than 7, you get blood. If you are actively bleeding, you get blood. The hemoglobin test is very bad at diagnosing active bleeding because you lose whole blood. So if you measure the hemoglobin of somebody who's actively bleeding, it's going to be the same. Why? Because you need time for water to diffuse into the intravascular compartment from the extravascular compartment to restore blood volume at the cost of the concentration of hemoglobin. So in this patient, believe it or not, I would give him IV PPI, large bore access, octreotide, and I would give him 2 units of blood empirically because I know I have no other reason for him to be tachycardic and hypotensive. A very small nuance that's not relevant for our conversation, but should be said out loud, is if you are worried about bleeding from portal hypertension, from cirrhosis, you should be careful how much blood you give, because over-transfusion of patients with portal hypertensive bleeding can increase the portal pressure and further augment bleeding. So it gets into a very tricky situation. But to summarize, Anmol, I think diagnostically, this patient, we really need to figure out what is the nature of their jaundice. That's going to help us a lot. Therapeutically, that's most of our work right now to stabilize the patient. IV PPI, IV octreotide, IV ceftriaxone, until proven otherwise. If you have no other reason for tachycardia and hypotension, give blood, because there are 2 indications for transfusion: active bleeding, independent of hemoglobin, and an anemia of less than 7. All right, Hans, why don't you tell us more?
Okay, next are the labs. And there we have the CBC. The WBC is 2000, which is low. The hemoglobin is 8, and that is low as well. And platelets is 90,000, which is again low. And I looked at the chart one more time to make sure, but it is pancytopenia. Then I have a liver panel because of the jaundice. And there I have an ALT of 60. The normal is between 7 and 56. I have an AST of 75, and the normal is between 0 and 35. And I have a total bilirubin, which is 4 milligrams. The normal is between 0.1 and 1.2. And I have a direct bilirubin of 2.5, and the normal is less than 0.3. And I have a chemistry, which is all within normal limits, nothing unusual: sodium, potassium, magnesium, calcium, all normal. And they also did a metabolic panel, which is normal. That is, they checked for the creatinine, which is 1.1, BUN is 10 milligrams, a fasting glucose of 90, a total cholesterol, which is irrelevant here, but I can mention it as well, which is 150 milligrams per deciliter, triglycerides 140, LDH was 90, less than 100 is normal, and HDL, which is only interesting for primary care physicians, which is 47, a total protein of 7, and an albumin of 4, which is again interesting for us. I also have a few other labs, and that is a hepatitis C, which is negative. I have hepatitis B, which is negative. I also have an AFP, so alpha fetoprotein for liver cancer, which is 10 nanograms, which is normal. A CEA for cancer of the colon, which is normal. And a CA 19-9, it's not diagnostic, but it indicates possibly a pancreatic cancer, which was normal as well. And this concludes aliquot number 4.
Oh my gosh, Anmol. Wow. Were you expecting those hematological issues? I wasn't.
Yeah, I expect everything at VMRs, honestly.
That's awesome. Well, you're way ahead of me, my friend. What is your mental summary now of the labs? What did you jot down?
Honestly, when I saw the hepatosplenomegaly, I was just hoping that I won't get pancytopenia kind of a picture in the labs, because that then takes the picture to another, that adds another differentials to the picture. But then if we see WBC is low, so we are not really seeing any immunocompromised state, but I think you've taught us that when WBC is low, we should get an HIV test to confirm. And then, but we see that all the 3 cell lines, they are low, so that paints a picture of pancytopenia. And that can occur in the case of some bone marrow disorders, or maybe some infiltration of the bone marrow. But to connect it with the other labs, which says that we have elevated liver enzymes, which can have like so many causes, like it's an acute liver injury, or but the enzymes are not really that elevated as well. They're mildly elevated, and we have elevation of both, I think, direct and indirect bilirubin. So I think ALP value will also help here, and direct bilirubin can be maybe some cholestatic picture could be present, which can cause that. I think that's what my random scattered thoughts are right now, but
It's
I'm not
hard to
able to.
Yeah, it's very, very hard to be organized. I think your initial suspicion of the liver is now reinforced. As you said, this is direct hyperbilirubinemia. So now we know we have some disease. And whenever you see liver disease plus GI bleeding, you have to worry about portal hypertension. So I think now I'm definitely going to keep giving this person octreotide. And the question is, how does liver disease overlap with pancytopenia? And the most important overlap is to think liver disease, portal hypertension, splenomegaly, esophagogastrical varices. So I think that chain of reasoning is really important, and it becomes really important to remember that we did have splenomegaly. And so now I think when we have marked cytopenias and splenomegaly, the question is, how do they overlap? And the simplest way they overlap is by virtue of portal hypertension causing a big spleen, and the big spleen sequesters all these cell lines. If there is no portal hypertension, then I think we have to think of a hematological issue connecting the two. So I think the simple problem representation now is to really try to understand Does this person have portal hypertension that explains their cytopenias through splenomegaly? Or do we have to explain the cytopenias and the splenomegaly in another mechanism? So in some sense, is there so much portal pressure that it's making the spleen big and eating up the blood count? Or is there another disease process infiltrating the spleen and the marrow? So is this a case of pressure, or is this a case of infiltration is the core question now? And I think, as you said, it's impossible to make progress without trying to see if this patient has portal hypertension. And I think the way we can do that is many ways, either with the endoscopy to see if they have varices, or with an ultrasound to visualize the portal vein. That is the most important question that's facing us now. If we are analyzing the infiltration hypothesis, we can get markers like uric acid, but one of them, an LDH, being low, pushes us away a little bit from the infiltrative disease, as many of them, though not all of them, have a high LDH. So that's my kind of simplistic formulation is it water that's infiltrating and making the spleen big? Or is it a cellular process? And I think we can assess water pretty quickly, and we'll see if that is the pathway or not for this case. Any questions about that, Anmol? Yeah, please. Of course.
Yes. So I just suddenly recall, if we talk about the causes of portal hypertension, like one of the causes is cirrhosis. So for example, we have liver, it's pre-hepatic, hepatic, and post-hepatic. So we can have many causes of portal hypertension as well. So even if the patient is not having cirrhosis, we can't really rule out portal hypertension. That's what you want to say.
Oh my gosh. One sec. Sorry, Anmol. I'm not sure if I caught most of you. I had my audio connected to my mic again, so I missed the last 7 seconds of what you said. Do you mind saying it again?
Yes, I was just wondering, when we have portal hypertension, so we can think of the liver causes as pre-hepatic, hepatic, and post-hepatic.
Excellent.
So cirrhosis comes in the hepatic category. So even if the patient is not having cirrhosis, the other causes can contribute to the patient having portal hypertension. So that's what I was thinking to evaluate in this patient. What could be the causes? Maybe I just remember one or two causes. Maybe Budd-Chiari syndrome is one of the cause. So that's what I was trying to recall.
Absolutely superb. I think that what you're reminding us is not to dismiss the diagnosis of portal hypertension simply because there is no overt evidence of cirrhosis. That's absolutely right. Portal hypertension, like pulmonary hypertension, comes in many flavors. Pulmonary hypertension is often due to cardiac disease, but can be primary. Portal hypertension is often due to liver disease, but can be from other conditions. And so just because somebody doesn't have left-sided ventricular disease does not automatically mean they don't have pulmonary hypertension. And just because somebody doesn't have cirrhosis does not automatically mean they don't have portal hypertension. And I really appreciate you explicitly making that point. And I think that is a key aspect of this case, because the liver abnormalities are not diagnostic of cirrhosis, especially the albumin of 4, which is not in keeping with cirrhosis at all. All right, Hans, tell us more.
Yes, we did exactly what was discussed. We went for the money and did some imaging and an upper gastrointestinal endoscopy, an EGD. I'll start with the EGD. And there it was quite evident, 3 columns of grade number 4 esophageal varices were found. The varices were banded with good hemostasis. Portal vein thrombosis with subsequent bleeding esophageal varices were confirmed during the EGD. No other lesions of the liver and pancreas, as far as the EGD was able to disclose it, were detected. And within this same imaging, we did an ultrasound abdomen liver, and I have actually a picture there if you like, but I can give you the summary. Hepatosplenomegaly was confirmed with a lesion. It was wedge-shaped in the No abdominal fluid collection was found. Hepatic enlargement of 18 centimeters, splenic enlargement of 15 centimeter, and a hyperechoic thrombus in the portal vein. So that concludes this aliquot.
Hans, I just have one clarifying question before Anmol dissects this data. Can you share with us, where was the wedge-shaped lesion, in the liver or in the spleen?
Yes, then I have to share
Okay.
the
think I made it.
screen.
Yeah. Okay, yeah, please go ahead.
Now let's see.
Take your time, no rush.
Mhm. Oops. Yeah, it's coming up. There it is. Looks like a shark's fin, and it's
Interesting.
in the portal vein.
I see. Understood. So the wedge-shaped lesion, is that representative of thrombosis of the portal vein? Is that what the interpretation is?
That was the
Interesting.
interpretation of the radiologist.
Amazing.
Thrombosis of the portal vein.
Interesting. Very interesting. Thank you so much, Hans. Anmol, I'll give you one more minute to think, just so I can just make recap what we've learned so far, because I think we're about to go into esoteria, but I want people to take advantage of a lot of bread and butter that a lot of the bread and butter. Remember, folks, we started with a patient who's having an upper GI bleed. And I think the question that we immediately asked was, are we going to give this person octreotide or not? And I think the moment you see any signature of any liver disease is the moment you give octreotide, even if that liver disease doesn't look like it's cirrhosis, because you're seeing how powerful it is that you can have portal hypertension without cirrhosis. I'm really glad that we gave this person octreotide. So you don't have to reach the threshold of cirrhosis to diagnose and to treat for portal hypertension. And now you're seeing it. You don't have to, you don't even have to have cirrhosis at all. And I think you're seeing how essentially we're really suspicious of non-cirrhotic portal hypertension as an entity. And Anmol, you already started us with a schema for it. Is it post-hepatic, intrahepatic, or pre-hepatic? And I'm curious now, what are you doing with the ultrasound with a big spleen, a big liver, and a thrombus in the portal vein? How are you connecting these things?
Yes. For the first thought that came to my mind when I heard wedge-shaped lesion was like an infarct, was a thought of an infarct. And then, and if we see a thrombus in the portal vein, then I just started thinking about the anatomy. For we have like liver, and then we have hepatic veins, portal veins, and that above connecting to the inferior vena cava. So if there is a thrombus in the portal vein, that means it is going more towards a pre-hepatic category, what we were thinking in the cases of like a Budd-Chiari syndrome. So that's what I was thinking. And if we think about it like that, maybe that's why the spleen is also congested. That was what I was thinking, and that's why its size is bigger. And if indeed it's found to be like Budd-Chiari syndrome, then we think of so many other causes which can cause like the most common of which was, I think, hematologic, that was polycythemia, I think. And the second one maybe related to I really am not able to recall that, but the first thing that just came to my mind that definitely portal hypertension can be seen from the esophageal versus grade number 3, and if it is not cirrhosis, it's something else, and if it's something else, then it's looking like pre-hepatic cause, like a Budd-Chiari syndrome.
Excellent. So, Anmol, I think that sometimes the terminology gets confusing about the names, which is why we're moving away in medicine generally from the names like Budd-Chiari or these syndromes, because they get confusing. So let's just put the names aside for a second. Where do you think the problem is? In the liver, in the portal vein, or post the portal? Do you think it's post, intra, or pre-hepatic? What do you think? Where do you think the lesion is?
It could be because I was just focusing on the thrombus, so
Yes.
it could be the pre-hepatic lesion because of that.
So you're thinking you literally see a lesion in the portal vein, excuse me. And so you're saying, hey, there's a portal vein thrombosis. That has to be the reason. Excellent. So the most common cause of prehepatic portal hypertension in the world is schistosomiasis. And the second most common causes are portal vein thromboses from hypercoagulable conditions. The most common hypercoagulable condition that causes a portal vein thrombosis is a myeloproliferative neoplasm. So if we think, Anmol, that this lesion is prehepatic in the portal vein, then we are saying it's either most likely schistosomiasis or a myeloproliferative neoplasm with a portal vein thrombosis. But my question, the hard question, dear Anmol, this is the part where you need to use all your neurons. If the patient has prehepatic issue, why is his liver big? What do you think about that?
That's what I was thinking, because thrombus in the portal vein maybe can cause congestion on the spleen side, but about the liver, why the liver was enlarged, it could, if there is maybe, we also saw the evidence of direct hyperbilirubinemia. So if there is a picture of cholestasis there, that can cause the enlargement of the liver or the congestion. I'm not sure about that.
It's very hard. The question about the liver is it enlarged because of water, or is it enlarged because of infiltration by cells? Is the same question we asked about the spleen. Water enlargement of the liver would not be explained by a lesion in the portal veins, right? Because the portal vein is proximal to the liver. So this gets really tricky, Anmol. So we have to think, is there a missed lesion in the hepatic vein that was not appreciated on the ultrasound, causing enlargement of the liver, causing stasis in the portal vein, causing a thrombus from stasis, and the real issue is in the hepatic vein, otherwise known as Budd-Chiari. Why am I thinking about that? The most common cause of Budd-Chiari in the world in total is Behçet's disease, which causes eye soreness through uveitis, mouth ulcerations, and urethritis. Right? That's why I'm thinking of it. But the other way we can connect this is that the patient doesn't have occlusion in the hepatic vein, but actually has thrombosis in the portal vein from a myeloproliferative neoplasm, like a JAK2, that causes extramedullary hematopoiesis in the spleen and the liver and the lymph nodes. So I don't know. The question is the liver enlarged from passive congestion with a missed lesion in the hepatic vein, or is it enlarged through extramedullary hematopoiesis? No matter what, there are two key next tests. The first is a JAK2 mutation for myeloproliferative neoplasms, and the next is a schistosomiasis review of systems about exposure and maybe an antibody. Those are the next two key tests. And then, you know what you might do on Anmol, might do on exam Anmol? You might go back and look at your IVs and see what has happened around your IVs. Do you know why that might be helpful, Anmol? Why would you look at the peripheral IVs for a patient who you're worried about Behçet's syndrome? What might you see? Do you know this? Have you heard of pathergy, Anmol? The concept of pathergy? Does that ring a bell?
Yes, I am not really able to recollect that, but
You've heard the word before? Yeah, pathergy is a very interesting phenomenon where patients get a rash at the site of trauma. And so in patients with Behçet's, they get a rash around their IV sites. And so I would do three things in this person. I would get a JAK2, I would do a schistosomiasis, and then I would go look at the IV sites to see if their rash has developed. But Anmol, this got very esoteric very quickly. I'm curious, what thoughts or questions do you have? What of this is what about this is unclear?
No, it's totally clear. I think I definitely confused with the terminology,
Yeah.
because the concept in that way was clear that portal vein is pre-hepatic, then we have the post we have hepatic vein, then splenomegaly can be understood, but why is the patient having hepatomegaly? So maybe something in the hepatic vein. So and I didn't know about the Behçet's disease affecting the hepatic vein. So that is definitely if that turns out to be the case, it explains everything. The patient having oral mouth sores and the pain in urination, it explains everything. So yes.
Yeah, I don't know how you just did that, where you learned all of that in the last 3 minutes. That was amazing. And then what did you learn about pathergy? I want to make sure that that concept got absorbed too. What did you learn about that?
Yes, I just learned that whenever if the patient is diagnosed with Behçet's disease, if a mild trauma on that patient causes a rash, so we insert the needle of IV needle, then obviously the rash will be there. So that just confirms our diagnosis.
Oh my gosh. Well, this is scary. I don't know how you remember literally everything. No, you don't. The only thing you don't remember is how well you remember. Everything else, I think you actually remember. Hans, tell us more, please.
Yes, because of the bleeding and the thrombus, a coagulation panel was done, and it's all within normal. That is PTT, PT, INR, protein C, protein S were checked, normal, prothrombin 20/10A, mutation, factor V laden, lupus anticoagulant, and cardiolipin, all of them normal. I think I can conclude this case by just mentioning the hospital course while the patient was in the hospital receiving anticoagulants for his thrombus. The nurse found one morning that when she checked the needle that was in his vein, that he had a big red bump. And I think that concludes our case. It was, as you mentioned before, Behçet's disease. On the other hand, if he has not developed this bump at the injection site, or he would have been discharged probably on anticoagulants. And I have learned that Behçet is a disease where anticoagulants are not very beneficial in dissolving clots. He might have developed, in all likelihood, an arterial or venous clot later on, and that could have been really massively serious. So he had to be treated for Behçet's syndrome or disease, which is a immunosuppressant. I think it's done with steroids and other immunosuppressants if needed. So thank you very much. This was an amazing discussion. I've learned a lot on top of it too. Thank you.
Hans, I think I don't know how much to thank you, because I think this case is literally a dream case for us to discuss on VMR, because for the first like 45 minutes, we were doing things to this patient and analyzing the case like I will do for the rest of my day when I go to work. GI bleeding, hemodynamic support, empiric treatment, cirrhosis, not cirrhosis. This is esoteria at the end of so much bread and butter, and I really, really appreciate it. And the truth is that if you practice outside the United States, you might not think of Behçet's as esoteria. It's not an uncommon condition in many, many places. So thank you so much for this case. I really appreciate it. Anmol, what did you learn? What do you think were your biggest takeaways from this journey?
Everything is a takeaway. And I really thank Hans for bringing the case, because I know each and every concept I have learned today will be embedded in me till the last breath, because I actually got to discuss that, and you taught so well, and you accept whatever I say, and then it's so great that you correct it right there and then I get to learn so much, and the case was really, really amazing. From the little details like a pathergy test to confirm our diagnosis of Behçet's syndrome. It's so amazing that it just shows that medicine in itself is so amazing. So I really loved the case.
Yeah, I
And
love.
thank you so much.
Yeah, I love what you said, that you'll remember everything to your last breath, which I think we all witnessed in real life, how you don't forget anything, which is really, really cool. it was a treat to be able to discuss with you, and it's really cool to see just how far you can go in a case, and you went the whole mile. I did not hold back a single question, and I think being able to go the whole distance with you is really, really cool and illustrates just how strong your knowledge is. Really big shout out to Francisco for jumping in and doing the teaching points. I apologize. I managed time very poorly. I have to hop on to another meeting related to work. So I made you, Anmol, the host. Are you able to stay for another few minutes for Francisco's teaching points, Anmol? Okay, awesome. All right, y'all. Thank you again, Hans. Thank you so much, Anmol. Thank you, Parisa, for scribing. And Francisco, I can't wait to watch the redo of these on YouTube, hopefully a little bit later today. Bye, y'all.
Right, everyone, what a case. So let's get started with the teaching points. So we started with a 50-year-old male that was throwing up blood for 1 day. So first, we need to check if the patient is stable. And we might jump to the diagnosis of emetmesis, which means blood, and emesis, that we may think that is from the GI tract. However, Rabih frames it as bleeding from the mouth, but from which orifice? Is it from GI? Is it from the lung? Or is it just nasal and epistaxis? So we first need to ask 3 questions. Is the diagnosis correct? What is the hemodynamic status? And does the patient have cirrhosis? And when we think about cirrhosis, we think about alcohol. And there are 3 causes of GI bleed, which can be malarivice through a tear in the esophagus, a peptic ulcer disease, or jaundice causing esophageal varices. Then when the patient presented with epigastric pain plus this bleeding, we started suspecting more GI tract. And given the fact that he had 2 cups of blood, the hemoptysis was starting to be unlikely. And we started more leaning towards emetmesis. We then, Rabih asked, what is more morbid, upper or lower GI bleed? And they are actually equally morbid. However, within the group of upper GI bleeds, it can present in 20% of cases as bleeding emetmesis, and in 80% of cases as melena. And melena is more benign because when we have emetmesis, the stomach is distended. Therefore, it's more acute and it can be quite severe. So we can frame this problem as a mucosal disease. There is affection of the stomach, the urethra, the mouth, and the eyes. And then we enter the field of how to manage the patient. So this goes well beyond the diagnosis because the patient is in hypovolemic shock. So we need to get 2 large bore IVs, type and screen, stop the blood thinners, start octreotide, ceftriaxone, because we are suspecting that the patient has portal hypertension. And we can also make a transfusion in these patients, but we must be careful because over transfusion in a patient with portal hypertension can increase the pressure and make it more severe, this portal hypertension. So now what do we have? How can we explain the fact that the patient presented with some labs compatible with pancytopenia? So we have 2 options. The liver disease could be causing portal hypertension, then hepatosplenomegaly, which causes sequestration and then pancytopenia. Or in the absence of portal hypertension, we could also think about marrow failure or infiltration. However, the LDH being low pushes a little bit away from this hypothesis. When we think about portal hypertension, we must think about pre, intra, or post. And the patient had an abdomen, ultrasound of the abdomen and the liver, and he had a wedge-shaped lesion. So now we have 2 options that could be explaining the portal hypertension. So we can have a purely prehepatic thrombosis, most commonly schistosomiasis or a myeloid proliferative neoplasm, that lead basically to a water and the dilation of the liver, or we can have a thrombosis only in the portal vein, and we have splenomegaly as infiltration of the liver and the spleen. So we started suspecting about Bassett's disease, which is one of the most common causes of prehepatic thrombosis. And to establish this diagnosis, we looked at the peripheral IVs, and the patient indeed had a pathergy sign, which is a rash around the IV site. And that's how we confirmed the diagnosis. And we got to the final diagnosis of this patient, which also has affection of the eyes, the mouth, and urethritis. So thank you so much for being here. It was a pleasure. Great case, Ans. Thank you for Shimano Describe. Great discussion, Anmol. Excited to see you tomorrow.
Bye. Bye, everyone. Great teaching, Punch Francisco. Thank you so much.
Bye.